That's not your product discrimination. You've already discriminated. They're the best and the smartest guy in the room, right? That's it. They're it. Yeah. The next point of discrimination is, do you do this procedure day in, day out? Third, approachability and accessibility. Their attention's on you. They've given you their mobile number. They're looking after you. You want that. And what's the final thing? A hospital and the 60 people that surrounds them, the engineers, the hospital workers, the recovery staff, the clinics, the outpatient facilities. So if it was a brand new machine and you didn't know how it worked, then the complication rate was almost 90% for the first 100 or 200 or 300 patients. But after that, the complication rate became zero. The predictive outcome was then to say, who's the older surgeon? Who's the one that has done the most repeatedly and with frequency? And who's the one that's been using the older machine, not the newer machine?
Sure.
Meaning he's used to the equipment, he's used to the facility, he keeps practicing, there's frequency to it. And at that point, he becomes zero risk. They're using that distance-limited technology, which relates to reconstruction plates. So they use that technology and say, well, if I just make that plate a bit longer, I can stretch that osteotomy a bit wider.
Up to, let's say, 8 or 9 millimeters.
Maybe if you're lucky. And there's only one reason why I developed all the plate systems and the designs for mandibular surgery. There's only one reason why I developed any of that is because fundamentally that other technology does not work. If you have a whole bunch of people that say, no, it does work, they're clearly not recognizing it, and deliberately so, because they're trapped within the system that surrounds them intrinsically, either because insurers insist that you use the cheaper system, not the more expensive system. The hospital insists because they're a public hospital and they can only afford the cheaper system in order to provide the service for free. You know, there are reasons why people get stuck with using the lesser system.
You think, though, that there's any merit to making people a little bit more mindful of mastication of food?
No.
Useful?
No. You just wear your teeth out. You're best not to have any teeth contact each other as you masticate. You're best to have soft food. You don't want to wear those cusps down. We're living longer. It just means this finite thing called an animal only has to survive longer. Chewing, forget it. This idea that a soft diet produces a small jaw, that's nonsense. I mean, all babies have no teeth and all babies don't chew. And it's got a Korean badge called a Kia. So Kia makes this SUV, but they only badge it. It's the Audi Quattro.
Is it the Telluride?
No. They badge it here in Australia as something different,
right?
Because if they don't have it, they simply lose market to Audi, or they lose market to Hyundai or whatever, and they can't make it in Korea. So what they did was they literally just bought Audis and took off the Audi brand and put on Kia brand, and it was worth 50% less. So I bought the Kia. But
wow.
Literally a remarkable vehicle.
Yeah. Kias are just going to the moon right now in the United States in terms of their brand image, in terms of the aesthetic of their cars. There was the Kia Stinger, which I think they've relabeled to the Kia, like, I forget, it's like X5 or whatever now, but the Kia Stinger there for a while was like one of the best value sports cars money could buy. I mean, you could get, I think 350 horsepower or something for like $45,000 US, which was incredible. And it was a super reliable car and a beautiful car.
Right. Well, you know, you're just buying chips and you're buying leather and you're buying comfort. You're buying those electric seats. You're buying the auto drive features like the auto steering and the lane control and speed control and distance to the car in front and the auto braking and stuff like that.
Yeah, the auto high beam. My buddy drives a Kia SUV, and I love that feature because driving at night, I mean, I have fantastic eyes, but driving at night is still scary for me sometimes, and I hate flicking my high beams on and off and anticipating the oncoming vehicle, and the Kia does it for you.
Yeah.
And it works really well.
Yeah, and they don't market it. They don't say, I buy this because, you know, we have so much auto intelligence built in, and you just buy it and you just get surprised by features and more features. I had all this stuff in the boot and I couldn't see through my rear view mirror. And I, for the first time ever, I pressed accidentally a button, or my dog did, and it turned on the camera so I could see the cars behind me.
Hmm.
And then I thought, oh, well, how many cameras has it got? And it's got like 10 cameras around it. And so you could get different pictures of all the blind spots.
Yeah, that's incredible.
It's amazing. And all the sensor technology in it, and it's got LiDAR and whatever, but they don't market it, which I find incredible. And it's the same with surgery. No one, I mean, lots of people ask me if I do counterclockwise rotations on with my bivacs, and I go, oh, buddy, literally, you cannot reduce your insight and expect me to market myself based upon the reduction of your insight as to what I really do when I do BIMAC surgery. And just with the car, when you get those features, they're called add-ons. They're value adding. You're getting a high performance vehicle. You're getting all the extras, the values, but you don't need to know about them when you buy them. You simply receive them, and it's the same with surgery. I call it value adding, and I get delighted when a patient says to me, "Oh my God, I did not know that you could do this. Did you fill out that crease, or did you turn up my nose? Did you make me able to breathe through the right side of my nose?" I go, yeah. And they go, I had not expected any of that. And I say, yeah, it's called value adding. You chose me, and you chose me because you trust me, and I will not abuse that trust. And Kia does that as well,
Yeah.
So I'm very
Yeah,
happy.
but if you're not choosing a surgeon based off of features, then how do you choose a surgeon?
Oh, well, that's right. It's like, how do you choose a surgeon? And I have no idea. Like I'm a consumer of health as much as the next guy, as much as any of my patients are consumers of health. Sorry, my puppy is just trying to chew every button off my jacket.
That's okay.
When you're when I go doctor shopping, as it were, I have the privilege of being able to be informed by the top people. My anaesthetist is a retrieval specialist for a helicopter service. So he can basically jump out of a helicopter with a shovel, scoop you up off the asphalt, and resuscitate you, take you back to hospital, and you will live. And he's my anaesthetist. And we've never, ever had an issue, ever, not once, in 30 years of working together. And so I say to him, I need this thing done for me. Who should I approach? And he will do the doctor shopping for me. He'll give me a range of names, a couple, and then I'll call them personally, and I'll talk to them. And if the first measure I think of a successful surgeon is if they give you their mobile phone number, and they're able to give that immediacy of advice. But what it tells me is that they have immediacy of access. They don't know me from a bar of soap, or maybe they do by reputation, but because I can get that immediate access right at the start, I know that I can rely upon that down the track. And then, of course, I do my own research as to the processes and procedures. And then what I'm doing is listening to them. And I often record people and play it back to myself, so that, there are things that I miss. And I re-listen to it. And I pick up on it and I research it. And then I come back and I'll have a few more questions. And, of course, it's my body. I'm in control of it, but I also take responsibility for anybody else mucking it up.
Mm-hmm. Mm-hmm.
And there she is. Her name's
But when
Pink.
it, but
So that's how you choose a surgeon.
sure. Sure.
You don't choose a surgeon because he's popular. You don't choose a surgeon because he's puts himself out there on social media or whatever, or says I've got the glossiest practice, or when you walk in, you see all the marble furnishings and so forth.
Sure.
I always say, you choose the older bloke, and you choose the wiser guy, the affable person that's engaged in the conversation of the technicality, rather than he wants to talk about his wife um, or maybe his puppy. You want to maintain the technicality of it.
Sure.
Um, so
Sure.
it is hard to product discriminate between people, especially if they're all using the same title. Um, but at the end of the day, it's the market is king. It's your responsibility to see who's out there, and you don't undersell it. Um, you you say, oh, you're going to charge me, I don't know, 10,000 for it. Can you do it for 8? Well, no, you don't ask that
Yeah.
because he's saying it's 10 for you, and it's 10 for the next guy, and 10 for the next guy. He's not varying the prices between people.
Mm-hmm. Mm-hmm.
And you also want to see demonstration that that he's capable of doing it. There was a great study I read in an ophthalmic journal, eyes, on laser eye surgery, LASIK, and they talk about the complications of laser eye surgery. And that's where you lie on your back and, you look at a little dot and they laser scour the surface of your eyeball. Now, the reason why I was reading is because I wanted laser eye surgery as well. And I wanted to look at complications and complication rates and how I as a consumer, would avoid going blind because I'm a surgeon. And the problem is, as a surgeon, going to another surgeon to have something which has the risk of blindness, or it's not blindness in the sense you can't see, but blurriness.
Sure.
What is that risk? And the surgeons, of course, they're all as nervous as pie, um, talking to you or even with the prospect of treating you, because if they cause this blurriness in you and you can't operate because of that, their reputation becomes throughout the community that
Sure.
he's caused this problem in the other surgeon.
Sure.
And that just spreads amongst all the doctors and all the referrers and all the hospitals and so forth. So when I go to the surgeon, I've got to be careful myself that I'm not exposing him to that risk or her. So I'm sitting there and I've done my research. And this is the research. The complication rates of laser eye surgery run at around about 4% or 3% of all laser eye surgery. But the complications, when they occur, only occur in one part of the bell curve. And what I mean by that is, if you look at all procedures of laser eye surgery that are performed, you can then measure out of that entire number the percentage of complications, known complications, a specific complication. And for this specific complication, you would say it's 3%. I'm just making it up, but let's say it's
Sure.
3%. Well, for laser eye surgery, it turns out that all of those complications don't occur evenly distributed through the bell curve. If you look down at the numbers, they occur only within the first 100 or 1,000 cases of a laser eye surgeon's practice. And it
Right.
occurs right at the beginning.
Mm-hmm.
So
Mm-hmm.
it occurs with two events. The first is that the ophthalmic surgeon's just graduated from ophthalmic training and he's just entering private practice. And so he really hasn't got a big experience. He's only done a few of these things in the public hospital system, but now he's entering the private system where they do literally thousands, and that's their entire forward career.
Mm-hmm.
And the other variable was how old the machine was. So if it was a brand new machine and he didn't know how it worked, then the complication rate was almost 90% for the first 100 or 2 or 300 patients.
Wow.
Well, incredible. But after that, the complication rate became 0.
Mm-hmm.
So then the performance or the predictive outcome was then to say, well, who's the older surgeon? Who's the one that has done the most repeatedly and with frequency, meaning he hasn't done 1,000 up to about 3 years ago and then hasn't done any since? And who's the one that's been using the older machine, not the newer machine?
Sure.
Meaning he's used to the equipment, he's used to the facility, he's practiced, he keeps practicing, there's frequency to it. And at that point, he becomes 0 risk.
Right.
And
So,
that's what I chose.
so what would be the analog for jaw surgery, generally speaking?
Well,
How could you?
the majority of jaw surgeons, the majority of them receive impacted wisdom teeth referrals from orthodontists.
Mhm.
And so you have orthodontics, from the age of 13, 14 for a couple of years. And of course, all 100% of people who have crowded teeth or bad bites, it's not because you have too many teeth. It's because you simply don't have jaws that are big enough to fit in all the teeth.
Of course.
And so they've all got small jaws. And so they have a process of orthodontics. That they call it, and I call it, camouflage orthodontics, because it's straightening the crowded teeth within the setting of having small jaws. So now they've got small jaws, but they've got this superficial arrangement of straightness, just mostly of the front teeth. But the back teeth, the last ones still are up to the wisdom tooth. And of course, what happens is, as they're trying to come through, the natural tendency of the original crowding to return is exacerbated by the attempt by the wisdom tooth to come through. And so the orthodontist will say, well, look, if it's endless stream of kids with bad bites and crowded teeth, and I put braces on during their teenage years, and can you, the oral and maxillofacial surgeon, remove the impacted wisdom teeth prophylactically before, they're going to upset my apple cart, which is, the straight teeth. And so all private oral and maxillofacial surgeons, 98% of their practice is dedicated to taking out wisdom teeth in post-orthodontic adolescence or young adulthood.
Sure.
And that's what they do. And so when you look at it objectively, all they're doing is 98% of the time removing impacted wisdom teeth. They're very, very good at it, and that's certainly my practice as well. But what I challenge is the need to remove premolars, which is also a part of oral surgery practice on behalf of orthodontists, alongside their wisdom teeth and so forth. And rather than as a true surgeon, making the jaws bigger. And of course, as a medical doctor, what you're trying to do is not treat what is a dental condition. It's not a diagnosis. It's not a medical disease, having crowded teeth. What you're trying to do is say, well, you've got small jaws and you've got sleep apnea, or you've got nasal breathing issues, and you've got these secondary consequences of it, like poor posture, and you can't run and you can't sleep and you snore like a trooper. So I say, well, look, I'll fix the jaws and give you a big enough jaw to accommodate all your teeth normally, and of course it corrects your bite, and so the orthodontic role is no longer camouflage. It's about just normally straightening them and straightening all of them, including your wisdom teeth. And that presentation is then I'm either a jaw surgeon making jaws bigger for fundamental medical reasons, or I'm a jaw surgeon acting as a secondary person to the primary orthodontist who's practicing camouflage orthodontics and is reliant upon the extraction of teeth. And the extraction of teeth includes the extraction of wisdom teeth. So if you get an orthodontist who says, I don't do any dental extractions with my orthodontics, but please go off to the oral surgeon and have your wisdom teeth removed, well, that very fundamentally is still having your teeth removed.
Mm-hmm.
And it's associated with other bits of surgery as well, like with the small jaw, you have the obstructed airway behind, but it's often interpreted as when you open your mouth, you've got these massive tonsils. Or you can't breathe through your nose, and let's de-obstruct it with adenoidectomy or reducing your turbinates or straightening your septum. So this idea that removing your wisdom teeth and having camouflage orthodontics somehow relieves you or helps avoid having corrective jaw surgery is a furphy, because you're still having jaw surgery, you're having your wisdom teeth removed, it's still performed by oral and maxillofacial surgeons, but it's committing you to all these other operations like the ENT surgeries,
Sure.
which you only find out about, months, years, decades after you've had the orthodontics in the first place.
Yeah, when it's too late.
When it's way too late, and you've got nice straight front teeth, but it doesn't match your face, and you snore, and you're putting on weight, and of course no one's making or connecting the dots. But the figure, if you want to draw out the dots, is you. You're the figure. It's how can all these conditions exist so close to each other, nose and teeth, and so I've got a blocked nose, I've got crooked teeth, I've got impacted wisdom teeth. It's all within an inch or two of each other. How can they not be related?
Of course.
And of course they are. And so how do you pick a surgeon for corrective jaw surgery? Well, you pick the guy that does it 98% of the time, and maybe 2% of the time, has to do something else. You don't pick the guy that does 98% of taking out impacted wisdom teeth and dabbles rarely in something that, the orthodontist doesn't want, and he's not that well practiced or versed in anyway.
Right.
If that makes sense.
So that would be criterion number one, would be find the surgeon who primarily does orthognathic surgeries rather than tooth extractions. But then even once you've gotten past that level, so say, for example, on my channel, I think let's say 10 or so oral and maxillofacial surgeons that I discuss on my channel that keep coming up from guests I speak to or referrals made by top orthodontists that I speak to.
Yeah.
What's the next layer of discernment besides finding the person who does only orthognathic surgeries? For example, how do you? This is the one that gets me. How do you find the person who is going to bring attention, quality, discernment the day of? How do you avoid the hack, right? Because anyone is only as good as they are in that moment. I mean, if you have Leonardo da Vinci, but he's hungover and he's in a hurry because he's off to do something else, or maybe he's been commissioned to do 10 paintings in a week instead of one painting in a week where he can focus and get it right.
Yeah.
How do you figure out who that person is? Who's the hack?
I've got a great way to explain that. First off, it is impossible to treat more than four new patients a week in orthognathic surgery.
Why is that?
Because the time commitment that's given just to one single patient is overwhelming.
Yeah.
Tell
us about that a little bit more.
Overwhelming.
So now we're getting a little bit more microscopic, and maybe in zooming in on this, we can identify some questions that could be asked of a surgeon. So, like, what's part of the patient workup process?
Well, if you're walking into a waiting room of a doctor, and he's got 20 people there waiting for him, to see him, he can only dedicate 5 minutes to each and every person. But if you walk into a maxillofacial surgeon and he's got 10 people waiting in the room, and you're there to have this incredibly complex process go on called orthognathic surgery, you're competing against those 10 other people for his attention, time, thoughts, mind. Yeah. You want to walk into an empty room.
Sure.
You want to walk into a room that's calm, devoid of all conversation, and it's all about you.
Mm-hmm.
And you want to be able to sit there and talk. You want to be able to explain your condition, be heard, be felt that you're heard. And of course, it flows on from there in that environment of it's all about you.
So, doctor, could we say in general that teaching universities and where an oral maxillofacial surgeon is employed would probably be a plan B at best, because the doctor is not really able to
It's not a plan B. That's a plan Z. That's a
really.
last desperate hope.
Hmm.
That's standing at the border at Ramallah, hoping that the Egyptians let you in, getting
Right.
out of Gaza.
Right.
Right?
Yeah,
That's
not a place you want to be.
you don't want to be there.
No.
Right? Do you know what an inducement to treat is?
No. Tell us.
Well, an inducement to treat. If you came to me for jaw surgery and I said to you, "Hey, can I treat you? And I'm going to give you a bicycle. Would you let me operate on you?"
It would be a huge red flag.
It
I
would be,
want the
wouldn't it?
surgeon who I'm chasing.
Right, but that's called an inducement to treat. Yes. Now, let's say you come and see me and you don't know me from a bar of soap. You've never met me. I'm 25 or 30 years old. I've got a white coat on. And I say, "Hey, you don't know me. Can I treat you? I've never done this before, ever. I've read it out of a book, but I'll do it for free. Would you let me do it?"
Negative.
Well, that's called an inducement to treat, right? I'm offering you either a bicycle or I'm offering to do it for free. Yeah.
Yeah.
Well, that's called a public hospital.
Hmm.
That's your
What's the
plan Z,
inducement? What's the inducement at a public hospital? What?
or you're getting it for free.
Right.
And the reward is that the fellow who doesn't know what he's doing is getting to give it a go.
Mm. Mm-hmm. Mm-hmm.
I mean,
Yeah. In
how
in
correct is that? Yeah,
hospital
philosophically.
at a big teaching hospital,
Or
the
who's
surgeon
teaching?
never chooses his own schedule. That's
Well,
imposed on the surgeon by the administration,
but they're not
and
surgeons.
they're profit driven
But they're not
exclusively.
surgeons. They're not
What
surgeons.
what are they?
Or you call them a surgeon.
Mm.
They're trainees. You
Mm.
only get to be called a surgeon when you graduate.
Yeah.
So
So
they're not graduated and they're being taught at a distance by somebody who's in their private practice,
right. Right.
right? So what you're getting is the late 20s, early 30s fellow or woman who doesn't know what they're doing.
You're getting the resident.
Yeah,
The resident is actually going to be um,
right.
cutting into you or
Yeah,
stitching you back up, and
yeah,
maybe the
with a distant instruction as to possibly how to do it,
yeah,
right?
yeah.
And
Maybe they'll call in
the
maybe they'll
inducement is to do it for free.
mm,
So,
yeah.
that is your option Z. I mean, it's there. And the vast majority of people who cannot afford treatment, that's their option because they say, "Well, I can't afford it. I will accept that inducement."
Mm-hmm.
Yeah. But me who can afford whatever, I'm not going to accept that inducement. I simply use the normal exchange of what we call money. And I say, "I will pay you because you're the very best at doing what I want you to perform. And I don't want these known complications to arise in me. And I will come to you because you, independent of the public system, have developed a hospital service in the private system, which has 20 other hospital staff, nurses, nursing assistants, surgical assistants, recovery assistants, anaesthetists, like retrieval specialists, the best, who are also paid to be the best and are all qualified, all fully registered, all fully trained already. And repeatedly, that team of people, repeatedly, over and over, do only that procedure. Now, that's your option A.
Mm.
So I, as a surgeon, I mean, you can see I'm just sitting here in a studio. I'm not a surgeon in this studio. I'm a surgeon in a hospital. I'm a surgeon when I'm surrounded by people and technology and instruments and safety. But you wouldn't have me operate upon you at a camping ground devoid of anything but a steak knife. You want
Right.
the facility. You want everything and all the accoutrements that come with being a surgeon, which is the hospital.
Sure.
So if you're walking into a dingy little surgery centre that won't let you stay in overnight and is only going to give you IV sedation and with a limited range of instruments and a surgical assistant who's never seen the operation or even knows how to hold a retractor, with a surgeon who is not used to performing the procedure and is instead just doing routine lumps and bumps, or just graduated, or is even falsely using the title of surgeon, and lots of people do, you walk out the door.
Mm-hmm.
Now, the reason why I know about that is because, you see the consequences of that, and they're called, can you please, 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 now I have the insight as to what I'm looking for. Can you please, please, please redo my Bimax, which is a ridiculously complicated operation, the repeat Bimax, because you're not just treating with a Bimax, you're reversing what the other amateur did beforehand at his reduced rate and inducement to treat for free or, subsidy or discount or whatever, just simply to induce you into a treatment that you otherwise would not have had
Sure.
if you weren't given the inducement.
Right.
Yeah. So inducement
So
to treat is such a ridiculously unethical practice to practice. And, any system that promotes it is just so fundamentally wrong. The premise of it is wrong.
mhm,
Yeah.
mhm. So let's take it a step deeper then. So you've found an orthognathic surgeon who exclusively does orthognathic surgery,
Mm.
chucks thirds occasionally as needed, but 98% of the time orthognathic surgery.
Yeah.
He or she is in private practice,
Mm-hmm.
chooses his or her own schedule, sees no more than, let's say, 4 new patients a week.
Yep.
You've gotten through those 2 big obstacles or
Yeah.
criteria.
Yeah.
The next step, how do you where do you go from there? What's the next question you ask? So for example, one thing I would be concerned of at that point is um, is this person going to perhaps under advance me? That's something I hear frequently.
Right.
Patients that have been under advanced.
Right.
Or why don't we start with that? Tell me what you think about that concern. Is that something you screen for, the risk of being under advanced because the surgeon is perhaps too cautious or too risk averse to make that
Mm.
bold move to give you the airway that you need?
Well, there's only certain technologies that enable you to advance beyond a certain point, and the technologies are commonly available to the surgeons. So if you chose surgeon A or surgeon B or surgeon C, they've got the same hospital, they've got the same equipment, and we're talking about, orthognathic surgeon.
Sure.
So it becomes dependent upon, the technology, just how far you can advance. So
Hmm.
if you're advancing a mandible and all you have available to you are what we call little reconstruction plates, which are about a millimetre thick. They have 2 holes on each side of the plate. They've got a central portion of the plate which is devoid of holes, being that the weak point of the plate is around the holes.
Sure.
And now the fixation is with screws, little screws which are a 1.8 millimetre diameter and penetrate cortex approximately 5, 6, 7 millimetres. So you've got 4 little tiny screws holding this jaw together on each side. So a total of 8 screws. The limitation of that distance that you can advance forward with that technology is approximately 4 millimeters, 3. It's not very far at all.
No, that's
You,
ridiculous.
it's ridiculous. So if you say, well, okay, I can extend that a little bit more by having a longer plate, or That's just like going on the end of a longer diving board. It flexes a bit more. So to reduce the flex, you use 2 longer plates, 2 on each side. But of course, you're still using, and your technology is limited to just the manufacturing capacity and the supply and the price and what your insurer is willing to pay for in terms of the limit of that technology. And now if you have 2 plates on each side, the limit extends to about the stable limit, meaning it will remain stable not the next day or the next week or the next month or the next year. It will remain stable forever. And that limit's around about 7 or 8 millimeters.
Still not even close.
Not even, well, it's not even 8, because you can only get 10 millimeter diastemer plates, meaning that the distance between the 2 inner screws is around 12 millimeters. You have to have the screw on bone, not space, not the space in between. So you've got to have at least a millimeter or 2 from the edge. So you're already limiting it to around about 8 millimeters anyway.
And just for perspective, there's patients that are getting, 1.5 to 2 centimeters of mandibular advancement, right?
The
So we're talking
the BSSO you're talking about. So
the BSSO, sure.
literally, how far is that stretching?
Yes.
That distance in between.
Yes.
Yeah.
Yes.
So it's 8 millimeters. So when you say, okay, well, now I'm getting, my surgeon said I've got 10 or 12, and I've had friends of mine say, because I have this debate with them about what the limit of that technology is, and they'll give me an X-ray immediately after having done the surgery, and they'll show it at 14 or 15 millimeters and say, see, Paul, I did it. And I go, that's okay. Can you show me that same X-ray in a week's time? Just a week. Forget about a month or 8 months. And what do you think I see?
It's probably down to 10 at that point. They've probably already lost 20%.
No, I don't see the X-ray at all. And every time I ask to see it, they never show it. Why?
They're not proud of the truth of the matter.
Because what's happened is the plate's bent under the load, or the screws are pulled out, or the whole thing's twisted. I'm sure you've sat on a chair with 4 legs and you've got all the struts holding it and it's nice and rigid. If you jump up and down on that chair, eventually it starts to wiggle and the little joinery sort of gives, and
Sure.
and you sit on it, it's a wobbly chair. Yeah.
Yeah.
Well, now that's your bite. Yeah. So now we've got the challenge. Here's the challenge. You've got a small jaw. Yeah. You've got to make it a normal jaw so you don't snore. And you've got to make it a normal jaw so you look good, and you've got to make it a normal jaw that you've got a normal bite. Not just teeth that meet, teeth that you can bite with.
Sure.
Into an apple.
Into a steak.
Into a steak. And for how long? A week? A month?
For
a
life.
Year? A life. Right. Forever. Yeah. And what? Are you going to be dependent upon the strength of that plate forever? No. You want to be dependent upon the intrinsic strength of the jaw forever. So you want to have the plate removed. You want to be un natural. You want to be yourself, right? You don't want to have evidence of your surgery. Eventually you want to have the plate removed. Yes?
Indeed.
But how many surgeons offer that? They go, no, we don't remove plates. And you go, why? Right?
And it's not because they're afraid of going in for that second procedure to flap the gums and take the plates out. It's because they're afraid of removing the plates and what that would mean for the structural integrity of the jaw.
Or they're afraid of what they're going to see.
Huh.
Yeah. The evidence and the proof of the failure of that system.
Right.
Yeah. So regardless, we've got to turn a poodle into a Great Dane. We've got to make a small jaw, which is small, into a normal jaw. Now, that small jaw might be a little bit small, or it might be a lot small. But normal is always the same size. Yeah? So the difference between small and normal can be small, or it can be large. Yeah? But whatever that distance, it has to be accommodated for all people, predictably, 100% of the time.
Mm.
Yeah.
Mm-hmm.
And if you can't do that 100% of the time predictably, because of the technology that you're using, which is limited by the size and the friability of it and its fracturability and its flexibility and its failure rate, if you can't do that, well, you're always going to limit yourself to 3 millimeters. You're always going to have people complain, I've been understretched. I underwent this massive operation and yet I'm undertreated.
Mm.
Yeah.
Mm-hmm.
So what you have to look for is the technology that enables those distances to be acquired, regardless of what the distance is.
So
From
what is that
conversion of small to
what is that
large.
technology, doctor?
Oh, that's me. Custom titanium. Right.
Custom titanium.
Yeah. And there's only one reason why I developed all the plate systems and the designs for mandibular surgery, which I wrote about in my book and illustrate ad nauseum. Yeah. There's only one reason why I developed any of that is because fundamentally that other technology does not work. And the only way I get to recognize that the technology does not work is by recognizing that it does not work.
Mm.
But if
So
you have a whole bunch of people that say, no, it does work, okay, fine. They're clearly not recognizing it, and deliberately so, because they're trapped within the system that surrounds them intrinsically, that defines either because insurers insist that you use the cheaper system, not the more expensive system. The hospital insists because they're a public hospital, they can't afford the more expensive system. They can only afford the cheaper system in order to provide the service for free. There are reasons why people get stuck with using the lesser system. Maybe that's their entire experience base.
that's probably a huge one. And as we were discussing earlier, a surgeon is only as good as his time spent using a certain tool,
Right.
right? You wouldn't even want the new, better plates by a surgeon who was doing, if you were one of his first 100 patients, let's say, right?
Yeah.
Statistically, there's
Spe-
a
well,
there's an
that's right.
exponentially higher chance of complication.
Yeah. Now, I can tell you now that all surgeons, every single one of us, are exactly the same. I'm the same as every other surgeon. I'm no better nor worse at operating at all. But if you want product discrimination, it's what do you add to that surgeon as a unit, as a whole unit, indivisible. They're not better or worse than each other. How do you find if that surgeon's better than the other surgeon? Well, it's not because the surgeon's better, it's because his hospital's better, his staff are better, his equipment's better, his
Tools are
philosophy's
better.
better.
Sure.
His support network is better. And when you walk in and see him, there are no other people. It's just you, because it's all about you. You're not being confounded or conflicted or having his attention divided on you by 10 other sets of wisdom teeth sitting in the waiting room.
So you said that your textbook includes an abundance of images that demonstrate what these plates look like and how they work, but could you just tease perhaps what is the difference between a custom titanium plate and the plate you described earlier? So the plate you described earlier,
Hmm.
2 screws, 2
Either
holes,
side, yeah.
2
I,
holes,
I,
and then
I, I illustrate it in the book. I
okay.
literally sat there and drew it. It took me 2 days just to draw a diagram to show the difference between the two systems. And
So,
when you
but
see it,
basically, what is it? Is it a bigger plate? Is it? Does it have a different alloy that is it
no,
that gives
it's
it a
all
certain
titanium.
strength? It's
There are differences in titanium alloys, absolutely.
sure.
And there's differences associated with the titanium alloy that you use according to the manufacturing process that you employ. So right now, there will be an image that you've got up, which I've shared with you, and that illustrates the two design principles. But on that design difference, you will have two different types of titanium alloy. The first will have a property of titanium which is able to be stamped. So if you get a titanium sheet and you have a cutting tool that can stamp it and take out a plate, that alloy has to be able to resist the stamping process without fracturing or work toughening, or, there are certain features of the alloy that enable it to undergo that stamping manufacturing process.
A certain malleability, let's say.
Yeah, and we're talking about titanium. Yeah.
Yeah, which is not a very malleable metal to begin with.
Well,
as,
in
as
its
far as
pure
I know.
form, in its
Right,
pure form, but it's
right,
incredibly tough. Yeah.
right.
But then you've got another kind of titanium which is used as a powder, and its manufacturing process is called selective laser sintering, which is a three-dimensional manufacturing technology. And where you get a powder bed of titanium within an argon atmosphere, and you selectively sinter the powder to form what is in effect a three-dimensional fused metal structure.
Right.
Now, the alloy that's required for SLS technology and the alloy that's required for stamping are two different alloys.
Of course.
And in function, they have a far different way of functioning. So the stamped alloy has a certain degree, as you said, of malleability or flexibility. They flex, and you can bend them, and they will not fracture. Yeah. Whereas the selective laser sintering alloy, as well as the manufacturing process, being that it's a sintered powder, produces and it expresses itself as a kind of elastic modulus within the metal itself. So if you do stress strain curves on the plate, you'll have a different stress strain curve for the SLS versus the stamped metal.
It's more brittle. The SLS is more brittle, let's say.
Right. You cannot bend it. It will not flex. It's rigid.
Similar to cast iron. You cast it, and
Absolutely. That's
it's
right.
hard as a rock. It's heavy. It's tough, but it is not malleable at all. It'll crack if you
Exactly.
hit it with a hammer.
Exactly.
Yeah.
So with that titanium, you will get what we call fractures or catastrophic failure of that metal in a certain function. So when it's designed, it has to undergo something called a finite element analysis within the design process of that specific plate for that specific individual. And so within a digital environment, predictive digital environment, you can apply algorithms to see how many times it can flex before it fractures at a certain weak point that you can predict. And at that point, then you design out that fracture area so that it doesn't fracture.
You fatten it up, let's say, in that
Yeah, you
specific
fatten
point.
it up. Yeah,
Yeah.
you find out
And
where the weak points are.
and
And
would
then
the
you
stress be caused by biting forces by the patient, let's say a week or two out of surgery, when they start
exactly,
clenching and chewing?
exactly. So you can think of it like a diving board, and you've got an incredibly long diving board, and you go right out to the end of the diving board and you jump on it, right?
Mm.
And it flexes, as you're jumping on it, because that's what a diving board does. But imagine a diving board that goes out, but it's not a diving board, it's a steel beam. Yeah, it's an I beam.
Yeah.
And you go right out to the end and you jump. It doesn't flex,
Right.
right?
It might snap if it's not strong enough, but it definitely won't flex.
Right. Well, titanium, think of a titanium bike and, the Tour de France. How many bikes, after they've gone over those little corrugations, have you seen that suddenly just fracture catastrophically? They just blister into a powdered shards of metal. Have you
I
ever
mean,
seen?
I haven't seen that, but I'm thinking of that Titan submersible that was made of carbon fiber, which is maybe a
Right.
more extreme version of the
Yeah,
sort
yeah,
of
just poof, and it's powder,
yeah,
right?
into a zillion shards of
Exactly.
carbon fiber fragments.
Exactly. Well, you get it with titanium bikes as well.
Hmm.
They go over corrugations and they're as rigid and as hard as anything. They don't flakes. They're not as good as steel bikes because they tend to flex a bit. It's a bit more of a comfortable ride. But with the titanium bikes, you go on the corrugations and bang, the whole bike fails.
Yeah, blows up.
Because it's rigid, it doesn't flex. And then when it fails catastrophically and suddenly.
Mm.
You can think of it like a fork. You're bending a fork back and forth, back and forth, back and forth, back and forth, and it snaps.
Yeah.
And that's a different kind of metal. It's a kind of stainless steel. Well, certain different types of alloy will do that as well in titanium. So you've got to match the design that you've got with the material that you have and the manufacturing process that sits behind it. And of
So
course,
you
you've got to
might,
have someone who knows about it, the surgeon.
of course, you
Yeah.
have to have someone who's done cases with both and has seen the limits of both alloys and the use cases for each.
Right.
So you might
And
use
what do you think that's dependent upon?
experience.
Right. Are you going to get that in the 20-year-old, 30-year-old in a public hospital?
No, I don't think so.
No, you
No,
did.
no,
It's
no,
nowhere near it.
no.
They're so far distant from it.
I don't know if I've seen a 20 to 30-year-old who I have found to be impressive or competent at anything recently, to be honest with you. I don't know if I would trust a 25 to 30-year-old with building me a cabinet.
Look, I can tell you when I was 25, I was delivering babies. I was admitting people into psychiatric hospitals and sedating them and putting them into padded rooms. I was removing people's appendixes and gallbladders and doing cesareans and a whole bunch of things. And everything else to do with surgery. I remember a patient coming up to me once and she was in labour and I'm the attending physician. I'm only a young bloke. I'm 25, 26, maybe 28. And she said, she's screaming. She's in labour pain, but she doesn't want the epidural and she only wants a gas. And she takes the gas mask off and she says, "Who are you?" And I said, "I'm Paul Coceancig." She goes, "And what do you do?" I go, "Well, I'm the doctor here. I'm going to help you deliver this baby." She says, "What are your qualifications?" And I said, "Bachelor of Dental Surgery." Now, madam, push. So I'm a dentist as well, but I don't practice dentistry. Obviously, I'm not using my dental degree to help a woman in labour. I'm using my medical degree, but I'm
Right,
still
but
in a public hospital. You get who
and
you
you had
get.
gone to dental school first and then medical school. Is that right? Is that how you ended up delivering babies as part of a what do they call them? Rounds?
Can I,
OB-GYN round, perhaps, part
can,
of your medical training after dental school on your way to becoming an orthodontic surgeon?
all right, this is how bad it gets. All right. I started dentistry when I was 16
Hmm.
and I finished by 22. I'm a dentist, doctor, Dr. Paul Coceancig, at 22. Do you think anybody would have trusted me with a filling at the age of 22?
I guess it depends on whether or not you had your beard back then.
No, I didn't have anything. I was glabrous. I'd barely gone through puberty. Um, the point is that, I'm a bit full of myself and I say, "I'm Dr. Paul Coceancig and I'm an expert dentist and I can do everything." Well, my mentors just sent me back to medical school and said, "Paul, you're too young to be, taken seriously as a professional dentist or dental surgeon. Go back and do medicine and we'll train you up and become a facial surgeon." But, and I thought, great. So I did medicine, but as a medical student, I'm also a dentist. And so all the people teaching me how to do medicine as a medical student, well, I wasn't very happy with just sitting in a classroom. I was going into theatres and I was saying to my professors and consultants, I say, "I'm not here to read books. I'm here to do it." So I just threw myself into it. I learned as much as I possibly could, and I enjoyed it, delivering babies and doing whatever. So, as a medical doctor, I'm now very, very cocksure, I suppose. But it's a public hospital, and you get to do whatever you want, really, because people look at you and say, well, I'm getting it for free anyway.
Right.
And I never hurt anybody. No one ever died under my care.
Thank
And,
God.
meaning, I went the extra mile to make sure I knew what I was doing.
Sure.
So I'm very well aware of how the public institutional education system works in medicine
Right.
and dentistry. And I'm very respectful of it. I'm just saying that from the perspective of somebody wanting the best, that is not the institution to go to. That's the institution you present for to, donate your disease to their adventure,
Right.
right?
Right. Right. Wow. So then let's take it a step deeper now. Um, you've identified a surgeon who meets all of the criteria discussed so far.
Hmm.
So what would you even ask a surgeon to know if they even offered um, these technologies, these custom plates that you're describing? Is there anyone else who even does anything like that besides you? So Dr. David Alfie came on my channel a
Hmm.
couple of months ago, and he said that he uses custom 3D printed plates, pre-plans it, pre-prints them, and then sort of plugs and chugs during the procedure. Would
Right.
that be similar to what you're describing?
Well, it depends on the setting that you're doing it. In the upper jaw, there's a custom guide and a custom plate that can treat almost the entire condition of the upper jaw. But in
Right.
the lower jaw, you need 3. And if you're doing double jaw surgery, now you've got 4 guides and 4 custom plates, and basically 4 times the cost of manufacturing, design, production, and so forth. So most insurers will limit it to the one plate, one guide. And thus far, I have never met anybody, I don't know anyone on the whole planet that does all 4.
So, so one guide. So what? So you're saying they just sort of dumb down their procedure in order to work within the confines of what the insurance will cover,
Yeah,
and you end up with a 75% less
yeah,
precise
yeah, right. So you've
procedure?
got, yeah, and so you're mixing the technologies. You're having the custom titanium, which is one technology and one kind of material and one kind of manufacturing and one supplier to the upper jaw, and that's the Lefort plate. And there are lots of manufacturers for that have emerged, and they are as different to each other as, I don't know, Africans to Asians to Indians to Europeans. They are not the same systems, but they market themselves the same.
As custom plates
Yeah,
and
under
custom
this
guides?
umbrella of custom titanium. Yeah. And then in the lower jaw, there is literally just one. And that whole manufacturing base is limited to one surgeon on the entire planet.
Yeah, right. Right. So, but
I
then
won't tell you who that surgeon is or who the manufacturer is.
okay, we can take an educated guess. So then don't they become if they're not using that technology on the mandible,
They're
doesn't
using the
their
older technology. They're using that distance limited technology, which relates to reconstruction plates. Which reconstruction plates are used for trauma surgery. So where you've broken something in the face and you reapproximate them to their original anatomical relationship. So it's, bone on bone, fracture on fracture. It's like putting 2 halves of an ice cube back together
you're not
and waiting for it
extending
to
anything,
refresh. You're not
you're just
extending anything.
reconnecting it.
Yeah, you're just reconnecting. So they use that technology and say, well, if I just make that plate a bit longer, I can stretch that osteotomy a bit wider.
Yeah. Up
But
to,
you're
let's
still
say, 8 or
defined.
9 millimeters,
Um,
maybe, if you're
yeah,
lucky.
maybe if you're lucky. Yeah,
And so
and
then
there,
they
there are
become
very many good surgeons out there, amazing surgeons who are fundamentally defined and limited by that technology. Meaning they'd
so
love to be able to go further, but they can't because the circumstances around them doesn't allow them access to the grander system.
the biggest circumstance being the patient's inability to afford that many more
Yeah.
custom guides in place, especially for the mandible.
Exactly. So their expectation is that they're getting it through their insurer. And when it's explained to the patient, no, your insurer will not pay for this, you have to pay for it. Then they go to another surgeon who, usually has a room full of wisdom tooth patients and says, can you do this? Because the other guy can't and he doesn't seem to have many patients in his room. Can you do this using, whatever the insurer will fund? And that other surgeon goes, yeah, sure, and does a 3mm advancement.
Right. Right.
So that's where you're getting the reports of people who are a bit, upset, maybe on Reddit, saying I've been under advanced.
Mm-hmm.
That's an incredibly detailed explanation of that one question, right?
Well, I think that's exactly the kind of explanation that my audience looks for. They don't come to my channel for generalities. They come to my channel for that sort of doctor level understanding of things.
Right.
And they can comprehend it. Believe me.
Well,
My audience is
if you're going to
quite brilliant.
product discriminate surgeons, right, you want them to have a degree in dentistry. I'm talking about maxillofacial surgeons, because it's not the training they receive in dentistry. It's dentistry doesn't make you a surgeon, but it gives you other skills. It gives you an understanding of material science. It gives you an understanding of how a dentist thinks. It gives you an understanding of how an orthodontist thinks, but it doesn't make you a surgeon.
Mm.
On top of that, you've got to have a medical degree. And the reason why you need a medical degree is because you've got to be able to resuscitate your patients. You've got to keep them alive. You've got to understand what death is and how to avoid it, and what life is, and be there and know how to be present when a baby is born. You've got to see the entire transit of life from birth to death.
Sure.
And you have to understand all the diseases in between and how to cure them. You have to understand how doctors think, how hospitals think. And then the final bit of the puzzle is you have to be trained very specifically in this area called maxillofacial surgery, and understand trauma and pathology and cancer and all the things that occur from the neck up, and understand it through the lens of, well, I've got a degree in dentistry, I know about teeth, and I understand it through the lens of being a medical doctor, through the lens of I've delivered babies, treated people psychiatrically, I've done everything in surgery, like removing appendixes, and knowing how to resuscitate people out of a car accident, right?
Why is all of that necessary for maxillofacial surgery?
Because you don't want to die from having an elective procedure to your face.
Mm. Mm.
You want to be able to recover, wake up, no pain, perfectly fixed, everything controlled, everything that you don't know about hasn't happened to you.
Yeah.
Yeah?
Yeah.
And you want that surgeon to be able to command the room of information. And I will say to you, every maxillofacial surgeon who has a degree in dentistry, who has a degree in medicine, and is a fully qualified registered maxillofacial surgeon, they are the smartest people in the room.
Mm.
You don't want someone else's opinion to second guess that.
Mm.
No orthodontist, no dentist, no GP, no chiropractor, no physio, no nurse.
No
Just the
dude on
fact,
YouTube.
no YouTube reviews, whatever.
No dude on YouTube.
Who? Dude on YouTube.
Yeah, me. No, I.
Oh, yeah, you, right.
Sometimes
Yeah,
I criticize people who are far more credentialed than I am.
right. No, that's not your product discrimination. You've already discriminated. They're the best and the smartest guy in the room, right? That's it. They're it. Yeah. The next point of discrimination is, do you do this procedure day in, day out?
Yeah.
Second. Third, approachability and accessibility, right? Their attention's on you. They've given you their mobile number. They're looking after you. You want that. And what's the final thing? A hospital. And the 60 people that surrounds them, the engineers, the hospital workers, the recovery staff, the clinics, the outpatient facilities, right? How are you ever going to understand any of that from a Reddit comment? How are you ever going to understand that from a Google review? How are you ever going to understand any of that just by word of mouth? You can't, right?
Yeah.
And
Yeah.
in the United States, it's some of the most amazing surgeons ever, yeah? But they are also limited and defined by the practical aspects of existing within a world that's defined by medical insurance companies that are massive corporates that, just literally look for profits.
Yeah.
Yeah.
Sure.
So you as a consumer, and I'm a consumer of healthcare as well, and it doesn't just apply to maxillofacial surgery. If I'm going to get my prostate removed, I want to go to a hospital that has a Da Vinci robot with a surgeon that does this 3 or 4 times a week and has a 0% complication rate. And if I have prostatic cancer, has a 100% success rate of removing that cancer and giving back all positive prognosis to that person.
Mm.
And yes, I will be his next patient.
Mm-hmm.
Yeah.
Mm-hmm.
I'm not going to go into a public hospital and just say, "Oh, just open my belly, remove it. Hopefully you can get rid of it all." I don't want to
Yeah.
hopefully.
Hopefully you didn't miss a piece.
I don't want luck. I don't want a surgeon saying to me, "Oh, good luck." I go, "Hey, I'm walking out the door. I don't want luck."
Mm.
So there's a saying. I made it up. I'll give you a joke, right? Have you ever gone to the horse races?
I have actually, but let's say
Who do you bet on at the horse race?
whoever the guy who's constantly at the track, whoever
Oh,
he's
he's
betting on.
advising you, right? But
Yeah.
mostly you bet on the favourite, right? If you want to win, you're just
Sure.
going to bet on the favourite for the next 10
Sure.
horse races, right?
Sure.
And eventually you
Sure.
get a win and you're happy and you've lost maybe $1, right? But me, if I go to the horse races, how do I guarantee I'm going to win?
I don't know.
Well, I'm going to bet on the favourite.
Sure.
But I've got one extra step that absolutely guarantees that the favourite's going to win. Do you know what it is? It's not luck. I'm going to shoot the other horses.
I see.
Right. And that's what a surgeon is. The real ones.
Mm.
Yeah. Every single one of us bets on the favourite.
No uncertainty.
No uncertainty, no luck, total predictability, complete confidence, total experience, knowledge. This is going to happen. Yeah. That's what makes every surgeon on the planet a very special kind of person. And
So
that's
when they
why they were selected to become a surgeon, because they had that personality.
Sure.
And then it was honed, it was crafted, it was chiseled out of the rough stone. And so that person that emerges, that's that surgeon, that older woman or man, they're not there saying that there's any luck in this. It's about doing it,
Yeah.
making it happen.
Mm-hmm. Mm-hmm. Is there if you had to have any surgeon in the world operate on you to do a maxillofacial surgery on you,
Mhm.
who would it be?
I don't know.
Really?
Yeah.
There's not a single soul
No,
that
not
you
one.
would entrust with your
Nope.
own surgery,
No,
even
not
if you
one.
had $1 million cash to
Nope.
spend.
Don't know one.
Hmm. Hmm. That's tough. No one in
Yeah.
the United States.
Nope.
Um, that's tough. That doesn't leave too many options for people. Is there such thing as good enough when it comes to
Nope.
maxillofacial surgery?
Nope.
Mm.
You have to live with that face forever in the mirror.
When they say that, someone said to me that I can't believe this is true, but they said 80% of maxillofacial surgeries are botched. Is that true? And if so, what does that mean?
All right, okay. Well, a good way of dividing what is surgery, is to understand it through the lens of the community understanding of what is a surgeon.
Okay.
All right. If I say to you, you need an operation, it could be for anything. Instantly in your mind is a 1750 image of a surgeon sitting over you in a chair with 5 people around you, stretching your legs out and your arms as they're opening your belly without anaesthetic, trying to remove that thing that's going to kill you otherwise. And your chance of survival of that is approaching zero, but it's not zero. Zero is not being treated. It's just above zero if they do treat you.
Yeah.
And that's the eternal image that people have of surgery. It's painful, it's invasive, but importantly, it's about removing something. It's about taking something away from you. A tumour, a splinter, a parasite, a bullet. Yeah. It's about removing something, and hopefully what's left behind can heal. Yeah. And it's painful, life-threatening. Of course, modern surgery is not like that at all. But in our mind, we're always worried about the act of going unconscious, of having things done to our palace, our bodies, without any capacity at all to object or scream or yell or interact. We submit ourselves totally to the control of this person who's a complete stranger. And we hope to wake up. That is the fear of surgery. It's a lingering fear, deeply entrenched in our culture, in our fundamental historicity of how surgery has developed and how modern surgery has evolved. To avoid those things, like with anesthesia and sepsis control and modern hospitals and diagnostics and everything like that that's come about to try to get away from that 1750 image of what is surgery. But it's still fixed and it's still practiced that we still remove body parts. So most surgeons remove body parts. They remove your appendix, your uterus, that tumour, that splinter, that parasite, that bullet. And so that's called ablation surgery. It's ablative. It takes away things. But if I say to you, hey, look, I haven't got an arm. It's been removed by the ablative surgeon, the amputating orthopedic surgeon, removed my arm after my car accident. He saved my life, but I lost my arm. What surgeon exists that can give you back your arm? Because that would
Peripheral
be,
nerve surgeon.
well, a whole arm. There is no surgery to give you back your arm. That's called reblative surgery. Reblative as opposed to ablative. Yeah. And so if you look for examples of reblative surgery, I challenge you to give me an example. But you can think of them. I'll give you some. You've lost a tooth and you get a dental implant.
Sure.
That's reblative. It's not anatomical, but it's pretty close. Yeah. And there's plastic
Periodontistry, gum grafts, bone grafts.
Right. Yeah.
Maxillofacial surgeon giving you your the genetically optimal jaw.
Right. And with IMDO, I can grow your jaw.
Sure.
Right. That's reblative. I'm literally growing your face. Yeah. So there are examples of reblative surgery. And if you really think about it, most reblative surgery techniques only belong to maxillofacial surgery. So we're the opposite of ablative. So you have two types now. You have the ablative version of a maxillofacial surgeon who takes away premolars for the orthodontist or takes away prophylactic wisdom teeth that are looking to becoming impacted, or they take out cancer, or they take out that lump, or they blah, blah, blah. But there's another kind, which is called the ablative surgeon, who gives you the bone graft, who grows that jaw, who gives you the dental implant, who gives you the gum graft. He's giving you back something that you did not have.
Sure.
Yeah.
Sure.
So when you're selecting for a maxillofacial surgeon, which one do you want?
The ablative, of course.
The ablative. Yeah. And through that ablation, they're restoring or deleting a negative. They're giving you back tissue or volume. I call it volume. But they're stretching out other volumes like your airway and taking away a disease called sleep apnea.
Mm-hmm.
They're giving you back teeth, and you might think, oh, it's just a tooth, but it's also a smile and self-confidence. But you also chew and bite with that tooth, so they're giving you back mastication,
Which is huge.
which is huge. And of course, through orthodontic surgery, they're just allowing you to chew. Yeah, they're giving you something that you didn't even know about.
Yeah.
There was a great quote I read on a forum somewhere. I thought it was your forum. Actually, I wasn't sure where I read it. The person who owned the forum said, I had jaw surgery for my class 3 mandible or class 3 malocclusion. And he said, I didn't recognize it, but looking back, it was like I was eating everything with a pair of scissors.
Mm.
And after the surgery, it was like someone put a food blender in my mouth. I could chew.
Mm.
I knew, I did not know what masticating actually meant. But afterwards, I did.
I'm a huge fan of mastication. One of my big influences before I even got into dentistry and jaw hacking, let's call it, was Horace Fletcher, who was known in the early 1900s as the Great Masticator. He was a health influencer in America in between 1910 and 1925, and his whole shtick was that he would go around and teaching people the importance of properly masticating food and how
Mm.
that could alleviate alimentary illnesses, digestive illnesses. His
Yeah,
whole,
my mother did the same thing with me. Don't swallow your food before you've chewed it at least 20 times.
sure,
And I go, why 20? Why not 21 or 19? Who's made that up?
yeah,
I've only 3.
yeah, yeah,
but, it's like, don't go swimming and after having eaten
yeah,
or you'll die of cramps.
sure,
Everyone believes it, therefore it must be true. But how can you
yeah,
die of cramps after eating? I've never
yeah,
seen
yeah,
anyone die of cramps. And
yeah,
everyone's eating around the pool, jumping in, and no one sort of go, oh my God, the cramps, I'm going
yeah,
to die.
yeah,
You know, I don't know. There's a lot of, anecdote and myth and mystery that, we all grow up with. And because we've heard it 1,000 times, it must be true. But is it? You know?
yeah, yeah. Well,
No,
I,
but
I
the
think
act
I
of
think when it comes to
masticating, if I
to
tell you objectively in science, what is the
mm,
act of masticating? It's to produce a mulch that is now got a little bit of amylase in it from your saliva, and the
mhm,
amylase is starting to break down some of the carbohydrate, and then it enters the stomach, and the stomach is a bag, a muscular bag, and then it further emulsifies it and becomes something called chyle that enters then into the lower pyloric sphincter, into the upper duodenum, and at that point it starts to get absorption of preferential nutrients, right?
mhm, mhm.
But that's called science, right?
Sure,
As opposed to, oh, it's good to chew your food 20 times before you swallow.
yeah, yeah, yeah. But probably chewing your food, let's say 20 plus times, facilitates whatever comes next. I mean, if you can pre-process the food and infuse it with
Sure.
saliva,
Yeah.
and Horace Fletcher's big thing was that he argued that by tasting food,
Mm.
um, tasting and enjoying food
Hmm.
actually resulted in additional gastric fluids being released depending on what you were tasting to
Right.
sort of break down that specific food. So if you took a moment to really masticate and savor,
Yeah.
you were improving digestion by actually releasing different chemicals
Sure. But let's
per.
let's let's talk about the environment of science in 1910 to 1920. They hadn't even developed insulin. They didn't
Right,
even know how diabetes worked.
right.
They didn't know what ketone metabolism was or versus glucose metabolism or gluconeogenesis from protein metabolism.
Mm-hmm.
They didn't know about how all the enzymes worked from the pancreas. They didn't even know how X-rays worked
Yeah,
because X-rays had only been developed in 1905.
sure.
All right. So you may as well be, I mean, 1920 was as rich and varied in opinion and human behaviour as we are now today. We just look at them in the past and think, oh, you're old. You must be more primitive. They're, they're, they're just working within the circumstances of an entire culture and thought system, which we have no insight into because we simply don't live in it.
Yeah,
So if you
yeah,
take any opinion from that period and look at it in an isolation, you're always going to be a little bit abstract. And of course, you're trying to relate their philosophy into our own
yeah,
modern culture. It's just, and it'll be the same with me. In 100 years' time, they'll go, oh, but Paul Coceancig said this in his book. We'll have no relationship to 2250 culture and
yeah, yeah.
society and technology. And I'm just an example of my times. That's all.
Sure, sure.
Yeah.
You think though that there's any merit to making people a little bit more mindful of mastication of food? You think it's a
No,
useful?
no.
No.
You just wear your teeth out. You're best not to have any teeth contact each other as you masticate. You're best to have soft food. You don't want to, wear those cusps down. We're living longer. It just means this finite thing called an animal only has to survive longer. Chewing, forget it. This idea that a soft diet produces a small jaw, that's nonsense. I mean, all babies have no teeth and all babies don't chew. They're limited to their mother's nipple in milk. They're on the ultimate soft diet.
Mm-hmm.
No, if you follow that philosophy, all I have to do is give this little puppy spaghetti and meatballs for the rest of her life and she'll have small jaws. And if I don't want her to have small jaws, I give her steak and she'll have big jaws. It's like, no, that doesn't work that way. She has a small
Hmm.
jaw or a big jaw or she's a little dog because she's a breed called a West Highland White.
Mm-hmm.
I know she's going to grow into a West Highland White because she was born to two parents who were West Highland Whites and she looks like a West Highland White.
Mm-hmm.
No soft diet's going to influence her or hard diet.
Hmm.
She's chewing on my fingers as I speak to you, so I am trying to stimulate her jaw growth.
So really, you're being serious? You think that the toughness of food, it makes no difference in
Oh,
jaw development?
it does to the size of your masseters or something. Just like what weightlifting. If you do, let's say, a simple curl and you build up your bicep muscle,
Mm-hmm.
where the tendons insert on the radial forearm or up on the upper humerus, and the
Sure.
acromion, those little bits that the tendons are inserted on will pull, and you'll get more Sharpie fibers in that area. And on an X-ray, it looks like it's a prominent muscle insertion, but that's basically the only influence on a bone that a muscle has. And in terms of the stress strain that's occurring on an entire humerus with the flexion through something called piezo, Piezo, piezoelectricity, the piezoelectric effect will give higher calcific or hydroxyapatite deposition in those areas of collagen matrix to strengthen those areas of flexion and to resist fracture. But it doesn't make the bone bigger; just makes it a little bit tougher in terms of the trabeculation or cortical thickness in that area. But I can speak to you ad nauseum about all these things because I rely upon something called science, as opposed to, I don't know, USA Today or some opinion piece given by somebody based on no science because they're journalists.
So if load on the bone from tough foods has no impact on the size of the bone as you grow, what does have an impact on it? Why do people have small jaws now with greater frequency than they did 200 years ago? Let's say, what's the cause of it all?
Well, that's a loaded question. All right. See this? It used to be a wolf. All dogs are wolves, but this doesn't look like a wolf. And it wasn't because I gave it a soft diet that it turned into a West Highland white. It turned into this with a white coat and a cute little face because it's called breeding.
Mm-hmm.
And it's the same with humans. All humans came out of Africa from a little place called the Rift Valley near Ethiopia, all of us. And around about 60,000 years ago, over a period of about 40,000 years, we periodically migrated out of the Rift Valley due to famine or whatever, or just following the herd. And we've just got spears. And coming up north out of Africa, across into the Sinai and up into the Levant, and then east to India and Asia and west across the land bridges that were forming as the glacial retreats were occurring about 40,000 years ago. And we displaced Homo neanderthalensis and maybe even mixed breed with the Homo neanderthalensis and the humans that came out of Africa that went to India and Asia. They crossbred with Homo erectus and Homo florensis and all the other, all the other Homo species that were endemic in those regions at the time. And there was a population that went as far south as Australia, and there was no Homo species there. And so, what came out of Ethiopia 60,000 years ago and went to Asia and 40,000 years ago into Western Europe, well, 60,000 years ago, the same population went to Australia. They're called Australian Aboriginals. And they're pretty much reflective of the original human wolf. But everywhere else, due to cultural isolation or cultural breeding or whatever, you got Caucasians, you got Asians, you got Indians, and that's the variances of man. But with Western culture, you've got this dimorphism of what we term Western beauty. What is the ideal female beauty versus the ideal male beauty? And the ideal female beauty is, you've got big eyes and you've got a diminutive face. And the ideal male beauty is someone who's got smaller eyes and a bigger lower face. They've got the same size eyeballs. All that's varying is the size of their lower face. So in that dimorphism, that sexual dimorphism, in trying to create a beautiful female, which is called neotony, neotony is what produces the big eyes, the Betty Boop look. Unfortunately, the genetics for that is not on an X chromosome. It's on an autosomal chromosome. And so boys get the Betty Boop look too. And it's called having a small jaw. But with a small jaw, you get corroded teeth, impacted wisdom teeth, and so forth. And then in the last 200 years, what you've had is the modern development of surgery. And surgery allows you to survive. You live longer. So if you've got an impacted wisdom tooth and you have a surgeon called an oral surgeon that comes along and takes out your impacted wisdom tooth, because if they don't, you're going to die of sepsis, of a neck infection called Ludwig's angina. Well, all you're doing is you're promoting the survival of people with that condition. And over the last 200 years, medicine has led to the increased survival of people with small jaws. That's it.
How
Now,
about breastfeeding? Is breastfeeding important for jaw development?
no, not for jaw development. It's just important for motherly bonding. It's important for nutrition. It's important to take in milk.
So this whole business about the suckling motion being helping to acclimate the tongue to coming up and forward and
No.
serving as a natural palate expander
Every
is
time I've ever sucked on a nipple, I'm breathing through my nose. There's a reason why I'm breathing through my nose. Is because to suck on that nipple, I've got to draw my jaw forward. By drawing the jaw forward, I'm also pulling the tongue forward. And by pulling the tongue forward, I can also breathe through my nose. It's the same thing with thumb sucking. The child with a small jaw does not know that their thumb exists because they're a neonate. They haven't even got consciousness. Up to 6 weeks of age, they're not even focusing on anything. But that child, if you lie them on their back and they've got a small jaw, they're going to thrash and turn because they can't breathe through their nose. And they can't breathe through their mouth because they're lying on their back, and they can't fall asleep because their tongue collapses. So the easiest thing they do is either lie on their front and breathe with their jaw open, like that, or they put their thumb in their mouth, their random thumb in their mouth, and to suck on their thumb, which is like a nipple, they have to draw their jaw forward, therefore pulling their tongue forward, and therefore they can breathe through their nose. There's nothing evil about thumb sucking. It's just a child's adaptation to, I want to breathe and sleep and breathe through my nose.
Mm-hmm.
And then we all demonize it by saying, oh, it's bad for you to have, thumb sucking. You're going to have a dentofacial deformity afterwards, or thumb sucking produces a small jaw. Certainly they're associated, having a small jaw and thumb sucking, but thumb sucking doesn't cause small jaws. It just causes an anterior maxillary dentalveolar adaptation around the thumb, which magnifies the effect of the bad bite that they've achieved from the small lower jaw. That's basically it. It's such a simple explanation, but if I speak to a speech pathologist or a midwife or a suckling nurse or something like that, they have all this weird advice that they give me, and because they're working in the hospital and they're wearing the coat and calling themselves whatever title they are, they think they're the expert in the room. And I just say to them, Madam, thank you. I appreciate it. I just want to enjoy my baby. And I, as a maxillofacial surgeon, will probably give them a better life than you might expect.
Mm-hmm. What do you think of the Weston A. Price work that shows that after just one or two generations of introducing sugar and Western diet into traditional peoples, that they have a complete collapse of facial structure? How do you make sense of that?
Well, that's the same thing. Exactly what I explained. It's called neotony. The ideal female beauty has big eyes. You select for the girl with big eyes. And over those 2 or 3 or 4 generations, you've got the background influence of medicine. It's called the cliff edge effect, by the way. It's given a formal name, where medicine itself alters the health of the population by introducing procedures that forever afterwards the community is dependent upon. I'll give an example of cliff edge
Sure.
effect later. But in Western society, as we've come to dominate the world and have influenced the rest of the world as to what is Western society, iPhones and writing and reading and speaking English and European ways and customs of doing things, we've also introduced the idea of neotony, that this is the ideal female beauty. That's not necessarily shared by all cultures around the world, but the Western cultural Greek-based view of, the Venus de Milo as the epitome of female beauty is now exemplified in Vogue magazine, where you've got, wafer-thin models on the cover saying this is the ideal epitome of female beauty. And that obviously influences not just white girls, but black girls and Asian girls and Indian girls. They all want to look like a white girl. And all the boys think that that's the epitome of female beauty because that's how they're sexualized. So people think that girls should have large breasts, big eyes, narrow necks, narrow waist. But is that necessarily what, a native human coming out of the Rift Valley 60,000 years ago believed to be female beauty?
Definitely not.
No, they just thought, can you provide, and are you childbearing, and do you have weight-bearing, childbearing hips, and do you have pendulous breasts in order to suckle the child?
Mm-hmm.
Right. The cliff edge model of medicine, the best example I can give to you is the incidence and rise of caesarean section in Western societies. And I'm talking about Western societies where Western society has been introduced. Yeah. So if I talk about Venezuela or Colombia, they're South American. They obviously did not start off as Western democracies or civilizations because they had endemic local indigenous populations, right? And then you had Europeans come in with their genes and they interbred. And so the population of Venezuela now, you won't find any indigenous population because they're all interbred with Western genes. It's like West Island whites going into the country and of a country of poodles. And they dominate the culture, and all of a sudden, everyone looks like a cross between West Highland whites and poodles. But regardless, in Venezuela, they've got something like an 80% rate of caesarean section. How do you have 80% of all women having caesarean sections at birth?
I don't know.
Well, the human tendency is always to have babies born with bigger brains, bigger heads. Yeah. And because we walk upright, we waddle with a wide pelvis. You only have to see an ape or a chimpanzee to see what a waddle looks like on a wide pelvis. So they tend to walk on all fours. Yeah. But we, in order to have gait and walk, you have to have a narrow pelvis. So you can walk and run. But in order to give birth, you need a wide pelvis. So women have wide pelvises and they give birth to children with small heads predominantly. And that gives us a safe, natural labour. You're able to have a wide pelvis that can dilate and extrude the human head, which has the human brain. Now, the moment you have a big head that's born on a child with a woman with a big pelvis, there is a good chance that you won't have an obstructed pregnancy or parturition, right? But if you're born with a big head to a woman who has a narrow pelvis, and she's got a narrow pelvis because we want you to have a narrow pelvis in order to walk, both mother and child will die of obstructed pregnancy, of the obstruction at pregnancy. So we developed something called caesarean section. We made it a safe procedure with sepsis and modern surgery in hospitals and so forth. And so those hospitals that introduced caesarean section only about 50 or 60 years ago, within a short period of time, 2 or 3 or 4 generations, have now got endemic populations with bigger heads, women with narrow pelvises, and now pretty much 80% rate of caesarean section. And entirely within a very short period of generational change.
Mm-hmm.
And that's called the cliff edge model of how medical care affects fundamentally the genetics and expression of baseline genes, which have a natural way of always remaining in the population, but have a reduced frequency of being there, big heads and narrow pelvises.
Mm-hmm.
And it's the same with impacted wisdom teeth. The death from impacted wisdom teeth or crowded teeth due to decay and gum disease and impactions and cysts and infections is quite high. So if you look at the London morbidity and mortality statistics, which began statistical medicine in the 1800s in London, where people are looking for all-cause morbidity, why do people die, blah, blah, blah. You'll look at it, and 50% of all people dying in London in the late 1700s, 1800s, died of sepsis of the teeth, or the pox, or, consumption, sepsis of the teeth, pox, consumption, fracture, accident, sepsis of the teeth. And you just read through the morbidity and mortality statistics, and then you can understand why oral surgery or dentistry developed as a profession is simply to manage dental extractions and to save people's lives. But all you did was increase the number and frequency of people surviving with small jaws and crowded teeth and this tendency to, reliance upon having teeth removed. So if you reduce the conversation to say, oh, haven't you noticed that in the last 200 years, you've got all these people with increasing frequencies and almost endemic frequency of small jaws and crowded teeth and impaired wisdom teeth? How can that happen in the last 200 years? Well, the explanation is crossbreeding with Westerners in all other countries around the world and the rise of the cliff edge model of medical care.
Well, I appreciate you presenting a contrarian view.
Oh, it's not contrarian. That's all science.
That's contrarian for JawHacks, certainly.
Oh, yeah, for maybe your audience, but for
For
my
my
audience,
audience, certainly.
it's called paleoanthropology. Paleoanthropology is where you study ancient man and you study DNA and you look for things, and then you've got comparative anatomy. These are all science-based things, and embryology and so forth. And that's opposed to anthropology or social anthropology. Social anthropology is an arts department sort of subfaculty that just looks at it from a perspective of, cultural study and studying people from in the last couple of hundred years. And it belongs to an area of traditional teaching in universities called theology. So the theology departments basically all became little schools for missionaries. And so these missionaries would go off to other cultures to spread the Christian word, and they became studiers of the local cultures that they entered into as they were doing their missionary work. And when they returned back to their theology departments, they became social anthropologists. So the tradition and the founding of social anthropology is founded in theology in most universities, and they're in arts departments. And then you've got paleoanthropology, which is a different department. It belongs to science and biology and DNA and forensic archaeology and things like that, pure science. And the two journals, social anthropology and paleoanthropology, two completely different disciplines, and two very different ways of looking at the world. So Coceancig is the person that you're referring to, looking at Kandahar in India. He went to Kandahar and said, I've noticed these Indian populations developing, small jaws, and I relate them to, soft diets and things. Well, he wasn't a paleoanthropologist; he was a social anthropologist, and based on, you may as well talk about creation and the Great Flood of Noah.
Sure, sure. So, what do you?
It's not science.
What do you make of the case of the twins that Dr. Mew has frequently presented, where you have two twins, presumably with identical genetics, but very different environmental cues as part of their upbringing, and they end up with completely different facial structure? How do you explain that?
Well, that's an unpublished treatise by John Mew. I know John. I know Mike. I like Mike. He's quite a nice guy. But these guys are not surgeons. They're not doctors. And presenting one pair of twins who have expressed their growth differently, and then giving all explanation to it and finding an entire philosophy of thought upon one observation. I have to say, at risk of, losing my friendship with them, that I don't accept it at all.
Fair enough. What do you make?
That's a variable of one, and I'm basing my own views on a variable of maybe 200,000 people.
How about Sandra Khan's book Jaws, where she presents the study of, I believe it's pigs, where
that they obstruct their nose.
It's either they obstruct their nose or they start feeding them slop instead of what they would normally eat, and their faces collapse.
Yeah, there are two studies. Mm-hmm. There's one on macaque monkeys that was actually done as formal studies, where they deliberately blocked the nose of macaque monkeys, and baby ones, and forced them to mouth breathe. And then they looked at the craniofacial development of the macaque monkey and noticed that if you block the nose, the whole midface doesn't develop at all, and they get terrible malocclusion. That's one. And the pig one, you could do a billion studies on pigs, but I'm not aware of what it is that, they've proposed what they're giving them soft diets and they've got smaller jowls or something, have they?
Yes, I think that's it.
Were
Basically,
these were these wild boars taken from the wild, and you know,
I don't know. But I
or
remember
were
vaguely
they a
that it.
breed of domestic pig that's already gone through the entire human breeding process of selection? And
I know it's the same animal. Diet is changed midlife, and there's a change in facial structure for the worse,
yeah,
along
compared
with
to
the
what
softer
though?
diet.
Compared to what? All the other bred pigs in an institution of which is artifice.
compared to
Because to
compared
be
to where
honest,
they were before the soft diet.
yeah, but I mean, I go to the local agricultural show every year, and I see those big fat sows, and they've got the 50 piglets around them, and they've got normal jaws, and all they're eating is slop.
Hmm.
So
What about the monkey study?
so
How
that's
do you make?
that's that, well, the macaque monkey thing is
Mm,
absolutely true. Now, the way the midface develops is you've got to have a closed mouth, you've got to have a normal lower jaw development, which, by the way, the lower jaw doesn't develop. It's the whole lower face that develops.
hmm
It doesn't develop in isolation, to everything else that's obviously there, but everyone's ignoring. Um, but you've got to have the dome of your tongue in the roof of your mouth to shape the shape of the palate and how the baby teeth come down the adult teeth, and that's over, 13 years from birth to 13 or 14 or so, as you've got to, whilst you're awake and whilst you're asleep, you've got to have your tongue to the roof of your mouth. It's very hard to do it when you're asleep and unconscious, and to do it consciously, but you can whilst you're awake and you're conscious and you're thinking about it, maybe. But most of the time, even when I'm conscious, I don't think about my tongue. So I'm relying upon its natural posture to be able to do that. But the biggest influence on midfacial development is the act of air, breathing through two nostrils, which are about 3 inches long, to the back of your throat. They're like two tubes or two hoses, and they've got sacs on either side of them called sinuses. So you've got to breathe in, breathe out 14 times a minute, 60 minutes an hour, 24 hours a day for the entire development period of your face in order to inflate the tire. So it's the inner tube that you find in a tire that you've got to inflate, that inflates the tire itself.
Sure.
And the tire is your face. But the inner tube are your sinuses, and you've got to be able to breathe in and out. So if you're only breathing during the day through your nose and not at night, well, in effect, your midface is about 50% smaller volumetrically.
Right. So
And
then,
you can see that over and over again. So if you're blocking the nose of a macaque monkey
mm,
right from the get-go, they're not going to have any sinuses develop. And
right.
there'll
So
be no
then,
nasalization or expansion or natural development of the entire midface. They'll look like weird macaque monkeys.
so
So
then the way we use our face does have an impact on the way it develops. So you're saying the tongue is a natural palate expander.
yeah, the tongue is a natural palate expander, but the tongue is also a natural mandible expander,
Sure.
right? So
So
the
then
tongue
follow
is
me
not
here
just
for
the
a second.
dome of the tongue. I'd say the dome of the tongue is that, but the underside of the tongue is
Mm,
what my finger's touching here. So
mm,
that's the tongue, right? So it forms that shape, which bears the teeth. So if you've got a small tongue, anterior tongue that is, you get a small anterior mandible and you get crowded teeth. And when the adult teeth come through, it looks like you've got an overbite or you've got
But
crowded
then
teeth.
if the tongue is a natural palate expander,
Hmm.
do you concede as well that, for example, breastfeeding teaches a person to keep their tongue pressed up onto the roof of their mouth? Or do you not even concede that breastfeeding has any influence on tongue position in an infant?
Or if you've got a naturally smaller tongue and with it the calcific element that surrounds the front of it being the jaw, the anterior jaw, it will sit back. So the whole tongue is back. Even if it's in the roof of the mouth, it's not forming a normal palate anyway.
But let's say you have a person with a perfectly normal tongue, but their tongue just isn't pressing up on the roof of their mouth because it never learns to through the process of breastfeeding and infancy, and it
No,
never
no,
goes
through
on
the
to.
process of adaptive mouth breathing. So a nipple in the mouth does not, I mean, it displaces the tongue away from the palate.
Wouldn't I would say that a bottle would be more likely to displace the tongue down and back because the nipple is just coming in and fluid is passively
No,
falling into
no,
the
no,
mouth
the
rather
whole,
than the.
no, the whole nipple thing, that nipple
Hmm,
is quite a big object to a little neonate, which you can't remember. I only know nipples from being an adult. But the nipple, with respect to the neonatal volume of the
hmm.
mouth, is quite large.
Sure, but it
And
do
they're
the
not just
milk
sucking
doesn't
the
just
nipple,
the
they've
milk
got
doesn't just fall out of it, though. The baby has to
no,
go up and suck the nipple out.
not the nipple either. They've got to suck the whole areolas,
Sure.
and
They've gotta they've gotta use
they're
a
milking it at
specific
the base of the
motion
nipple.
to draw milk from the breast, the nipple,
Yeah, yeah,
whatever we wanna
it's a
call
proper
the whole
milking.
complex.
Yeah, it's a proper milking action, but that nipple is drawn well down to the back of the tongue. It's not
But the
in the
tongue
front
is
of the
coming up and forward to create that action, is it not?
exactly, but it's not the tongue. The whole jaw comes forward with the tongue, with the tongue to, you know, clasp
Sure.
the areola nipple base, and it's
And
milking
now
it.
when the nipple is no longer there, the tongue in the jaws are still they've trained to be in that position as
Well,
opposed to being down and back with
they
the
can't.
fluid simply falling in.
They can't. What? That child is asleep like 18 hours of the day. Like there's puppies asleep all the time. When they're
Sure.
unconscious and asleep and totally relaxed, there's no conscious thought. And they're a baby. They have no conscious thought even when they're awake. There is nothing
But
there.
is conscious thought really necessary to develop muscle memory of that sort?
Yeah, but regardless of muscle memory, muscle tone and muscle activity only occurs when you're awake or in light sleep. It doesn't occur when you're in deep, relaxed sleep. Nothing moves. You're relaxed. You're asleep.
So
All the
then
training in the
with
world,
that logic,
everything.
then why doesn't everyone have sleep apnea with their tongue falling back into their throat if the tongue isn't able to have tonality and being up and forward during
Right.
sleep?
Because there's a magic muscle under here called the geniohyoid
Mm,
that has to contract to open up or pull forward the epiglottis. And that tone is what you become dependent upon if you have a small jaw in order to maintain the patency of the airway behind it.
mhm.
When you lose that tone, that muscle, which has to super contract, relaxes and it collapses the airway. In the normal size tongue and jaw, the relaxed geniohyoid, when it relaxes to its maximum limit, right, it doesn't, it's still not, um, the airway behind it is still patent.
Mhm,
So in the normal jaw, you don't need to contract it to open up the airway.
mhm,
But in the abnormal jaw, you have to contract it consciously or through habit or through adaptation or, holding your head forward or whatever to keep that airway open.
mhm,
When you lie on your back and now you've got the influence of gravity and you're going into deep sleep and that muscle relaxes, the epiglottis substrates the back of the
mhm,
airway, and that's the genesis of obstructive sleep apnea.
mhm.
Now,
So then,
that's a highly technical explanation, but
no,
it's best illustrated
it's a
in.
good explanation.
Well, what I'll do is I'll just give you some diagrams to help illustrate to your audience what the hell I'm talking about.
Sure.
Um, so you can see it, and it's like, oh, that's bleeding obvious now that I see it. Um, because I can use however many words and it makes me sound smart or whatever, only because I know the words exist. But, I'm a surgeon. You have to expect me to know something.
Sure, sure. Um, I guess I'm just not ready to accept that our habits have no effect on our facial development. If you yourself conceded that uh, the monkeys whose noses were plugged because
But that's not a habit. That was an imposed imposition. It's not a habit.
it's an imposed imposition.
Mhm.
However, perhaps that same imposition is habituated
Well, that's a
through.
presumption, in a premise that the imposed imposition can be reinterpreted in a different setting and call it a habit. But there is no
Well,
demonstrable habit that leads to it. There's only the premise that that idea of an imposition can become a habit. So
well,
philosophically,
let's take an allergen then. An allergen can have the same effect of plugging the nose. Let's say a child grows up with 10 cats in the house,
yep,
and now his nose is blocked because of inflammation due to dander in the air.
okay, all right.
Now he's not
Well,
breathing through his nose.
yep,
Now his uh, the air is not passing through the nose. The balloon is not inflating. The tongue is not up and forward because
mhm, mhm, mhm,
he's doing
mhm.
that. Could that lead to poor facial development?
Okay, my dog, he poos on my arm, and instead of washing the poo away, I leave the poo on my arm, the poo on my arm, for the next 3 months. And eventually, when I remove the crusted old poo from my arm, what do you think the quality of the skin will be underneath the poo?
Poor.
Yeah, it'll be red, inflamed, it'll be itchy, it'll be sore. Does that mean I'm allergic to poo?
In a sense, I would say sure.
But not medically. But I would say having poo on my arm causes redness and inflammation and swelling in the skin immediately underneath the poo. It doesn't really mean to say I have an allergy to dog poo. It just means I'm an unclean person who doesn't know how to, clean myself up or take showers. It's the same thing with the nose. If you don't breathe through the nose, there's no natural airflow through the nose. And what the nose produces is mucus secretions. The purpose of the mucus secretions is to collect those pollens. If you do not breathe through the nose is still producing that mucus. And within that mucus, there is still entrapped particles like dander, like pollen, like whatever else that's floating around in the atmosphere. But instead of being cleared, now that mucus is stagnant. It's not flowing with the flow of air to the back of your throat so you can swallow it and get rid of it. So now you've got stagnant mucus filled with all this pollen. You can call it dog poo. And now the membrane that's immediately underneath the dog poo or the pollen or the dander or whatever is now red, itchy, inflamed, and swollen. And now you're waking up because you're breathing through your mouth with stagnant mucus in your nose, full of all this detritus with dermatophagoides terranescens or dust mite, fecal particles, pollens, dander, your own cells desquamated throughout the night. In this mucus, sitting against this membrane that's now inflamed, and you say, oh, that's the reason why I can't breathe through my nose, because it's blocked. And you go, no. The reason why it's blocked is because you're not breathing through your nose. You're not naturally clearing the mucous membranes and all the rubbish and whatever. It's like a dry creek bed.
Sure.
It's
But
got stagnant water in it. All the health ecology of the creek is just not there. The
but why
moment you
has this
introduce a
person stopped
natural
why
water
has this
flow,
person stopped breathing through their nose all of a sudden? Something has been introduced environmentally to
no,
trigger
no,
to tr-
no. It's because they've simply got a small jaw. They lie on their back. They obstruct. So what they do is they lie on their side with their mouth open and breathe through their mouth. And that means there's no airflow through the nose. That means that they've got stagnant mucus, which is collecting all this stuff, and it's sitting there forever. And they don't wash their nose out to clear it. And the membranes get inflamed. And secondarily from that, because they're not breathing through their nose, there's no natural inflation of all the membrane sinuses, the healthy sinuses, which are inflamed and red and swollen. And so you get an underdevelopment of the midface, and with that, of course, all the crowded teeth and the look like, a bit like a Habsburg princess, the big
Hmm.
looks. Even though they look like they've got a big lower jaw, they actually got a small lower jaw in this chronic mouth open breathing, which produces a secondary effect of maxillary maldevelopment.
How about when I visit a friend's house who has a pet, let's say, and I'm breathing perfectly through my nose before I get there, but
Yeah,
I've been there an hour now, and all of a sudden I'm stuffed, and I
right.
start breathing through my mouth. Has
Yeah,
not the animal present or whatever the allergen is? Maybe he's smoking. Maybe my
yeah,
friend is chain smoking cigarettes, and I'm
yeah,
feeling stuffed, and I start breathing through my mouth.
yeah.
Hasn't that triggered mouth breathing for me, which, if
Okay.
it persists, would
No,
result
that's okay.
in me
I'll go
becoming
back.
a mouth breather and then having poor facial development?
I'll go back to the poo on my arm analogy. So now I've got red skin, but I've cleaned the poo away. Yeah, but it's still red and it's still inflamed and whatever. And now I put poo back onto it, and now it gets itchy again. It's because it's always itchy because I haven't given enough time for the redness to go away. And so I keep blaming the poo on my arm as to cause the itchiness in the skin and the redness. But really, what it is it's just never the swelling, the inherent reactivity of that inflamed membrane has never gone away.
Hmm.
And so when you reintroduce the same thing that caused it in the first place, being poo, you then come to believe, because it's a repeat event, which reinforces the idea that you're allergic to poo. But you're not. You just got inflamed membranes that were made inflamed by the presence of things that naturally irritate. If you look at a pollen particle under a microscope, it's got little spikes and little things on
Hmm.
it that physically irritate things.
Hmm.
And if you look at Dermatophagouides terranicinus, it's just poo. Poo. Dermatophagouides terranicinus is that mite commensal that has existed with humans for the last 20,000 years. It's called house mite or dust mite, and they live on our bodies to eat our desquamated cells,
Cells. Hmm.
and they produce fecal particles. And when you lie in your bed and you've got a bit of bright sunlight, all that little particulate matter that you see through the bright sunlight, that's a mixture of your dead skin cells and Dermatophagouides terranicinus feces.
Hmm.
So it's that feces of the Dermatophagouides that is what is chronically resting against your membranes. It doesn't mean to say you're allergic to poo. It's just that it literally is physically irritating to you.
But regardless of whether we call it an allergen or whatever we call it, it's something in the environment that's altering the way we use our tongue and our mouth and our nose. Is it
Yeah,
not?
yeah. Obviously, we weren't raised to live in bedding and mattresses and in
Sure.
artificial caves. We didn't
Sure.
evolve
So,
that.
so then
And
the environment can have an effect on our facial development.
absolutely. And you're about to have a baby, right?
That's right.
So, and you're not going to go and live in a cave in the woods, are you?
No,
No, you're going to live
sometimes
in
I'd
that
like
house.
to, but I
So all
won't
the
be.
accoutrements that come with Western living are imposed
Correct.
upon you. You can't avoid them. You can only adapt to them.
Correct.
So what can you do?
Yeah, I guess that's what I'm asking you. So then, if I
Okay, well,
from what I've
here's
heard
rule
from
number
you,
one. Here's rule number one.
sure,
Right?
sure. Mm,
Buy a new house that no one's ever lived in, where there is no skin cells from 20 years of the previous occupants occupying the carpet and the walls and the ceilings and everything. It's called dust, right?
mm, mm.
Buy a brand new house. Yeah. No
Well,
concrete. So you don't have
that's
concrete dust. Yeah.
but a
You
new
buy,
house is just going to have all sorts of other stuff in it.
well,
Paint, fresh
maybe
paint finishes,
fresh,
spray
the
foam,
volatile things that might,
polyurethane from the
right.
floor.
Yeah. Yeah. All of that. So go back to the cave in the woods, right?
Yeah, yeah.
But when you buy that new house, have total control over the materials that go into it. Employ the architect. So I don't want that paint. I want this paint. I want that. I don't want this. Blah blah blah.
Mm,
You have to
mm-hmm.
pay a bit more. Okay, but forgetting about that, what's the next best thing that you need to do? Buy all new furnishings and have tiles, have wood parquetry, things that you can sweep. You're not reliant upon a vacuum cleaner.
Mm,
Have big windows live in a part of the world that's not too humid, not too dry,
Mm-hmm.
that you're not dependent upon, humidifiers and air conditioners forever. But if you can't depend upon humidifiers and air purification systems to reduce the particulate load in the atmosphere that you're, breathing, don't move to Beijing in China, right? Choose Colorado. But the best one to pick, I could tell you, right? Who have the biggest cheekbones in the world?
Haitians.
No, Eskimos or
Hmm.
people that live in Scandinavia in
Hmm.
cold climates because they're
Hmm.
forced to breathe through their nose the cold air to warm and humidify it. And they've got lovely big cheekbones, the Russians. Wonderful.
Hmm.
Yeah. Yeah. But you're not
Yeah.
going to live there. You want to live in a nice Florida kind of atmosphere, nice
Well, I live
warm
in
atmosphere.
Massachusetts. It's pretty cold here.
Well, yeah, but only for several months of the year, not all the.
Six
Yeah,
months.
right. So maybe you're close enough to a glacial field to be able to experience the wonders of being able to breathe through your nose, nice, cold, icy air. Be a walrus, right?
Yeah.
Big noses, big snouts, big
Sure.
turbinates,
Sure.
smell everything, right? You can do that. But
So
devoid of
we're
that, the only thing you can do is just get fresh sheets, do
Mhm.
regular airing of your bedding in the sunlight. Yeah. Don't use the dryer. Yeah. The washing machine. Put your vinegar into it. Put your Sards Wonder soap. Put your the proper kind of detergent that dissolves and completely gets rinsed away. And repeat. Get a brand new mattress once a year. Don't have
so
carpet. Don't have
so
curtain.
we're talking air quality now, and air quality is obviously important because poor air quality can cause a stuffy nose, which causes mouth breathing. But are there no other environmental cues or activities that can also influence the tongue coming up onto the roof of the mouth to serve as the natural palate expander? You don't think that tougher foods lead to the tongue coming up and forward? You don't think breastfeeding leads to the tongue coming up and forward?
Oh, the breastfeeding does, obviously, has to promote to suckle and milk the
Sure.
nipple. You got to draw the jaw forward and suck on that
Yes.
nipple.
Yes.
You got to, and,
Which which would
absolutely.
then which would then
And
influence
it's
facial
wonderful to
development.
watch. As an adult, you look at it and it's the most beautiful thing. It's
I totally
mesmerizing.
agree. I'm excited to see it.
Oh, yeah.
I'm excited to see it firsthand
If
when my
if a
baby is
woman's
born.
breastfeeding beside me and they put a drape over it for modesty, um, I just stare. I just think it's just the most natural, beautiful thing as well. It's not sexualized or anything. It's just human.
Yeah,
Yeah, it's beautiful. And for us to demonize breastfeeding, oh, what kind of society have we become?
I agree. But you won't concede though that breastfeeding can influence facial development in a positive direction.
It's just part of natural human development. It's not a. It's not a. I don't consider it a thing that you say, oh, you must breastfeed because we so demonize it and you don't need it and you have to
Mm,
feed on bottles and it's socially inappropriate to breastfeed and, we're humans, we're not animals and so forth. We're not promoting it on the basis of that.
mm,
We're promoting it on the basis of, well, that's what you do because
mm,
we're humans,
mm.
you know. Um, so you don't say, oh, you breastfeed because it's going to lead to normal facial development.
You
That's
don't think
not.
the science bears that out?
There is no possible way you can form that argument and be taken legitimately. You have to say, no, you breastfeed simply for the act of breastfeeding because of all the IgA and IgM that you take in through the breast milk, that natural immunity, all those nutrients that child needs as
Chemically,
well,
chemically, breast milk is important. You're saying
where do you get
Uh,
all your gut flora from?
totally from raw milk. I think it's a
Oh,
great
well,
source.
no, it's from your mother,
Your
from
mother's
touching
raw
her,
milk.
from sucking her skin.
I see. I see.
Yeah, and that's what pops.
Totally.
Yeah, and so your whole alimentary system, we, we're not one human, one living being We're a collection of about 1 trillion different animals.
Totally.
We're an ecosystem.
Mm.
We just don't see it, and therefore we don't acknowledge it, right? But you've got to acquire normal gut flora. You've got to acquire proper nutrients, and you've got to acquire proper proteins in the form of immunoglobulins through that milk, and all the macronutrients that come from milk as well. But you're not going to live on it. Obviously, the teeth start to come through, and the kid starts to nibble, and the nipple gets a bit painful, and so you've got to transition to, you begin with softer food. That child's not masticating until they're about 2 or 3.
Mm.
And it's only until they've got their full adult teeth, which is at the age of 12, and their full adult teeth at the age of 18, with their wisdom teeth and 32 adult teeth that's supposed to survive for the next 80 years. Yeah.
Mm-hmm.
That whole human intercourse, of course, every step along the way. Nature designed it over 4 billion years of life, 2 billion years of eukaryotic cellular evolution, multicellular organisms, and finally the adaptation from fish to mammalians and reptiles, and from mammalians to simians, and simians to apes, and apes to humans, and Homo species, or genus rather, becoming Homo sapiens and Homo sapiens sapiens. And then through Homo sapiens sapiens, all the various different breeds of us, which are Caucasian and African and Indian and Asian, trying to adapt and somehow survive to these effects of breeding, human breeding, that's come only from 10,000 years of civilization. And 10,000 civilization is a patch on the 300,000 years that Homo sapiens sapiens has been on the planet.
Sure.
Right? So
It's the fingernail clipping.
right. So if you talk about just the last 200 years, I mean, what? Serious? 200 versus 2 billion? Evolution works over a very long time span. It's not evolution. There's nothing called epigenetics with this. It's literally, you get a cosmic ray from a supernova 5,000 light years away, and it hits a particular part of the DNA and turns tyrosine into guanine or whatever through, quantum mechanics, and ultimately leads to that variance in the DNA chain and protein change from its transcription to how it ultimately expresses itself within the entire conundrum of all proteins and all systems that ultimately develop the human. I mean, the entire complexity of that, which belongs to the universe and God or whatever, my human brain is incapable of knowing it.
Yeah.
And to impose then upon me an opinion given by a journalist in a book, writing insightlessly without any science, and it's like, what? Are you kidding? And where's the expression of that point of thought? They're not treating anyone. I do. So the people coming to me, they don't want my philosophical discourse. They just want fix it. Make it go away. Get me off the CPAP machine.
One thing is for sure, regardless of the cause of the small jaws, the solution is irrespective of the cause. So, I mean, if you have small jaws and you need surgery, it doesn't really matter how you ended up here in the first place. But what really does matter
is that you're fixed. Yeah.
Is getting it fixed and getting it
Because
fixed
if you have sleep
optimally.
apnea, you die of that eventually.
Yeah.
But with a shortened lifespan, and in that shortened lifespan, you're suffering from all the diseases that cause your ultimate death.
Yeah.
Yeah. All the effects of high blood pressure and obesity and diabetes and vascular disease and all those things that occur from a poor night's sleep, like car accidents and workplace accidents and whatever. All cause morbidity from sleep apnea is 15-year reduction in lifespan.
It's incredible.
It's incredible. What a statistic. So
horrible.
if I go to someone, I go, I've got sleep apnea, right? My only demand will be make it go away. I want a 100% guarantee it's gone. I don't want philosophy. I don't want a 20% chance or a 50% chance. I don't want you all bloviating, trying to convince me that some splint or chewing a harder diet's going to help me or something in my past has caused this. I don't care.
Yeah.
I just want it gone. And I
I
want the
think.
technology that you give it to me in your best experience with your best team with a total 100% guarantee and satisfaction that I am cured.
Mhm.
That's it, right?
Certainly for adults, um, all that matters is fixing it. I think when it comes to raising healthy children, trying to come to a conclusion about the importance of certain environmental factors on how a child's face will develop, I think
Mm.
it's important to wrestle with that question. I appreciate your contrarian view, contrarian with respect to the guests I've had on this channel before.
Mm.
I appreciate it. It's certainly food for thought. I'm not totally sure I'm convinced yet. Um, I still think that I'll
But I
err on.
keep asking you to buy the book,
Yes,
right? In the
yes,
book, which is,
yes,
several hundred pages,
yes.
thousands of illustrations, logical A to logical B to logical C to D, E, F,
Hmm,
establishing the premises, establishing the theorems, establishing the fundamental proofs, and proofs are what are demonstrable to you as evidence and which can be repeated
hmm,
independently. All these things, that's a book. That's a world expert that writes the book,
hmm,
because world experts who are not world experts don't get published.
hmm,
Right? You have to be a
hmm,
world expert, a thought leader. You have to be the inventor. You have to be smart. You have to understand things from multiple different scientific perspectives, as much as from the human perspective of the person in front of you. That one of 4 patients a week, that your time, your brain is committed to their welfare, and they survive and they live a happy, attractive life, able to masticate and breathe and sleep with a normal smile, and they don't snore. And,
hmm,
and they're free of the consequences of snoring.
hmm.
You know,
Yeah,
that's
yeah, yeah.
that's what I do for a living. And I have colleagues that do that too as well. But they exist in different parts of the world. They don't exist next door to me. We're not common on the ground. And there are people that want to occupy our seats, and that's fine. That's called life. I die, they replace me, as
Well, I
I
don't know if you
replace
can be
someone before
replaced.
me.
I don't know if you're going to be. I don't know if you're replaceable.
Oh, no, 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 no. I'm just a normal bloke. I can tell you, I'm just a normal bloke. I just mow the lawn. I mow the lawn. I've got kids. Um, I go on holidays, and and unless I'm in front of someone like you, I certainly don't bloviate and go on and on about whatever. Now, the
Well, of the
easiest
eight
thing for
billion
me is
people,
just to write a book and say, read it.
sure,
I
sure.
prefer to drink red wine and talk about, I don't know, footy or
I,
soccer. No, no, I'm not. I'm not esoteric that way. I'm not a new age man or anything.
you
Um,
strike me as a pretty esoteric guy.
oh no, 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 no. I'm literally a normal bloke.
Can you be someone who cuts into human faces for a living and sees that deep into someone's face and not be esoteric? I mean, isn't that philosophy in and of itself? It's definitely a contemplation of death and a contemplation of the
It's a
body.
craft. It's just a skill that I've acquired because special people gave it to me and mentored me and educated me and took me in as their son. And I treated them appropriately and properly as my masters. And um, and I'm forever grateful for the gift of the education and scholarship that they gave to me, and the institutions they introduced to me over several countries in the world. And um, but I don't define myself by being a surgeon. I define myself by being a father and a brother and a son and a friend and a supporter to my patients, who are all strangers to me when I meet them, but they're not strangers to me after I've met them.
Mm,
And I take all effort to know them in every way, because I'm a doctor. I treat the whole person. I'm not a dentist treating just teeth or with a focus on a particular body part. I treat the whole person. And I used the medium of my surgery and the focus upon the face in order to be able to treat bigger picture things like sleep apnea and all the medical effects of that. But I'm not there as their toe surgeon or their penis surgeon or their shoulder surgeon. I'm focused on the face. And I'm completely, professionally obsessed by it, but I'm not socially obsessed by it. Just a normal bloke, just like you. And you're about to be a dad, and you're about to find out the joys and wonder of that baby. And it begins with, it doesn't begin. It's just part of it is the parturition being there. I was the attending doctor for my children's births.
Wow,
I
really?
delivered them. Oh, yes, I'm a proper doctor.
What are you
Um,
doing next weekend? I need
I
someone.
can fly over. I could be there for you. But, I'm an unlicensed doctor if I come to Minnesota, so that's not quite ethical.
I
But,
would trust you over whoever the heck is going to be there
oh,
next
no,
Saturday.
gosh, no. You're just relying upon my affability and personality to make that judgment. Um, but the reality as a father, it's a wild ride when you do it. And to see the joy of breast suckling and nappy changing and bum wiping and showering with your child, your baby on your arm. Oh, can I give you one bit of advice?
Please.
Sleep with your baby.
Hmm.
Have them suckle your finger at night. Yeah, they'll suckle
Sure.
your finger throughout the night. And that's what I did with all my children.
Really?
This little finger here, I would rest them on my arm, on their tummy, stroke their back, my little finger in their mouth, fully to the back of the mouth. They'd just suckle it and they'd fall asleep.
Wow.
And I did that for all my children for the first 8 months of their lives. And I had the best night's sleeps. I was just so content.
Wow.
And my children have beautiful faces. And I am their father. And I've looked after them. And that's what you'll do with your children as well. I enjoyed it thoroughly. I did it
I really
five
appreciate
times in a
that.
row. Five
Wow.
times in a row.
You have 5 children?
Yeah.
That's amazing.
Oh,
That's
I'm just,
amazing.
it's only because I'm very attractive and very fertile. But,
No doubt about that.
but the joy of being human is experiencing everything that's human, the biology of it, the fundamental naturalness of it.
Mm,
Everything around us is just fluff and bubble. All right.
totally.
Yeah.
Totally. That's what
Well,
I'm in it for. I'm in it for the deepest possible, most authentic human experiences.
yeah. Yeah. And that you
That's it.
can't get
That's
more
my
authentic
core
than that.
philosophy, is to just
Mm.
I think you called it paleoanthropology, paleobiology. I'm just trying to find out, what cavemen are supposed to do, and that's how I'm trying to live my life. No, really,
Right.
and that's
Well,
and
we can't really. We can't. This little thing here will never become a wolf.
no,
She's through breeding dependent upon my attention of her.
sure,
She'll never be able to hunt. She'll never
mm,
be able to, take wild game. She'll never be able to survive anything other than my cuddles.
yeah,
And so I'll just show it to the camera. There she is. Look at
there
that.
she is. Oh yeah,
Look at that. Little West Highland White.
she's like a little Eskimo.
Her name is Penny, and she's got black skin, so she won't get dermatitis.
You'd
She's
never
got
know
this.
that she had black skin under that white
Yeah.
coat.
Well, you look at that snout. Look at that snout.
Oh yeah,
Those
she's like
eyes.
a black mamba.
Yeah. I
Opens her
did
mouth and it's black.
did all the DNA testing, and the mother and the father lived on opposite sides of Australia, so there was no interbreeding. And the breeder's an accredited breeder, and it's fully licensed, and what you get is a perfect temperament, and and a puppy free of diseases, and one that's perfectly happy, and goes to hopefully me, a good master, that will train her. But that's the same with children, you
Hmm.
know.
Hmm.
Yeah, and we all live in a village. We're all reliant upon the people around us to make that child perfect.
There's no doubt about that.
Yeah,
Yeah, we have tons of support, um, and that's a big consideration of how my wife and I chose each other. she has a mother who lives nearby and 4 sisters.
That's
And
right.
I have my mother and my sister, and my mother is already helping to raise 3 nieces and nephews. So it really will be a village with my baby girl. And that's a huge consideration, because the parents that I encounter who are really stressed these days are the ones who are just doing it themselves, that have
Mhm.
no
No family.
parents
No.
helping, no siblings helping.
Mm.
I think that's really hard, and I don't think that's natural.
No. No. We evolved to be part of a tribe.
100%.
Yeah.
And fortunately, I have that. I wouldn't have done it if I didn't. That's not an accident.
Well, you're a terrific guy. You get on really well with your dad too, don't you? And
Yeah, we run a business together.
he's raised a terrific son. Yeah.
Uh, he'll never hear you say that, because he doesn't watch JawHacks at all.
Okay.
I don't think he's ever seen a single video of mine.
Right.
But maybe I'll show him that clip, and he'll appreciate that.
All right. Well, I'll let you go, and thank you again for talking to me.
All right, Paul.
Hopefully,
So
we do it again. I
we
don't
got to
mind talking.
do. What'll we talk about in round 3?
Oh, whatever you want.
Maybe more technical stuff.
Oh, okay. Oh, so boring,
Maybe
but
boring. Maybe we'll
I
do
mean,
a
I've never been able to entertain anyone in a conversation about my work.
well, you've come to
It's,
the right place for that.
all right, all right.
Maybe we'll
Okay.
pick a philosophical question, and we'll dive deep on it.
Yeah,
Love,
yeah,
or
yeah. I mean, I'm
something.
55. I'm set in my ways already, but I still listen to people. I still take it in, and I try to absorb it and see how it relates to everything that I already know and know that works. Um, there's not much that there's not much that you know that I believe in that isn't based upon a lifetime of experience of testing whether it's true or not.
Yeah, yeah.
Um,
And let's be clear. I'm not here to the point of our discussions is not for me to impart anything on you. It's simply for me to extract
yeah,
what's in
challenge the
you
thoughts.
for the
Have me
audience.
defend them. Yeah.
It's to yeah, like you said, I think in our text, it's basically I'm here to get out of you, or to give you to what did you say? I forget what it was, but essentially to trigger the bloviation, or to be a
Oh, the
uh,
bloviating. Yes.
yes, yes,
I
yes,
think I think that was from the Congress, the Illinois Congress. So you had a congressman in the Illinois State Parliament, or you don't call it Parliament, you call it House,
sure,
and he stood up in the 1800s and yelled over at the other congressman, probably from the other party, and he said, "You're a blah 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 blah," and he just made up the word on the spot. He said, "You're a bloviating idiot," type of thing. And it became a word, and a perfect way to describe someone who just goes on and on and on and on and on.
Well, do you know another way to describe such a person is a sophistical rhetorician inebriated by the exuberance of his own verbosity.
Oh, that's right, and lubricated by alcohol. Yes,
Indeed, indeed.
that's a very
All right.
good one. I like that one.
Yeah.
All right,
Thank
you
you.
have a great day. Good evening. Go to
All right,
bed.
Doc.